to switch gears to talking about some of the most common questions that we get at Frame, because I'd love to have Dr. Mbaye and Dr. Stevenson talk through, again, some of the questions or maybe myths that you've heard out there that we want to unpack today. So Dr. Mbaye, I want to start with you. Would you talk through some of these questions and kind of the facts underneath the surface?
Forgot to unmute. So to start on the top left there, it does say, what role does age play? Does that only affect women? And we know age does affect both partners. So with patients who have eggs, we typically will see that egg counts tend to accelerate in terms of how quickly they go down after age 35. But something that a lot of patients don't know until we tell them is the fact that your eggs, as soon as you start having periods, are starting to go down. And so we know that that is a constant process. We just know that at age 35, that just tends to happen a little bit faster. So that's why there's that change in waiting 12 months versus 6 months once we get to 35. With patients with sperm, we typically do see that quality starts to go down around age 40. I know it seems unfair because for women, advanced medical ages or advanced maternal ages at age 35. For men, it's closer to in their 50s. But it is something to kind of consider, even though it's not something that's talked about as often. Another thing that comes up a lot is whether or not family history matters. So if your parents didn't have any issues, or if they did have issues, are you going to have the same kind of story? And we do know that that tends to be a good indication of whether or not you may have issues down the line. A lot of times if parents or siblings or other family members had issues getting or staying pregnant, that may be something that you might have to deal with as well. So it would be a reason to go see either your OBGYN or see a specialist, an REI specialist. Another one that we see all the time is birth control. That's probably the most common thing I see as an OBGYN. That's a question I get probably every day. A lot of patients are on birth control for a very long time. If you started your birth control in high school for really painful periods or heavy periods, you might be on that for 10, 15, 20 years before you decide you want to get pregnant. Birth control in and of itself does not affect fertility, but we do know that it's very important, to know what your periods were like off birth control, which sometimes people don't know, again, because if you've been on birth control since you were a teenager, you're not going to remember that. But I always will tell people we want to see what your periods are off that birth control, because if you don't have periods off birth control, to Dr. Chappell's point, that's something we want to talk about as soon as we find that out, rather than waiting a year later and you're like, oh, I never had a period. So definitely something that we want to kind of suss out for patients. And then also considering the fact that it does take a little bit of time with certain birth controls for your period to return. So that's always something to kind of talk about with your doctor as well.
Thank you so much. And I'm curious, what's the average length of time somebody should wait until they raise their hand and say, I think there may be an issue here for coming off birth control?
So for me personally, I like to give people 3 months because I feel like that's enough time for most things to have re-regulated back to normal. If you've come off birth control and it's been 3 months and you haven't had a period, please come in or do a telehealth visit or something.
Wonderful. That's very clarifying. Yeah. Great. All right. Dr. Stevenson, will you cover a couple of the other ones?
Sure. So we talked a little bit about the top one about the female issue at the start of this conversation. I just want to expand on that just a little bit and just talk about why I think there is such a misperception, and I think it's in part because of stigma that's associated with infertility. And a lot of people don't like to talk about their experience with infertility. And it's actually a little more common than I think a lot of people understand, is that it can be upwards of 15% of couples experiencing infertility. And like I said, people don't generally talk about it. And I would say that that's a little more common for men than it is for women if they're experiencing infertility. And while it can be upwards of 15% of couples, there's good news because the majority of issues that are identified, there are treatable options. And so to the bottom left one, is IVF the only option? And the answer is no. There's lots of treatment options, and it's going to be very specific and related to what the underlying issue is for the woman, the couple, whomever is trying to seek the pregnancy. And so it could be something that requires very high level medical treatment, or it could be something that is a lot less complicated. Could also be lifestyle, addressing some of these lifestyle factors. I know Dr. Chappell talked about that earlier as well. But I think that a lot of people don't understand that lifestyle really does have an influence on fertility, and making those lifestyle modifications, addressing things like diet and smoking and alcohol, marijuana use, and also just stress, sleep, those sorts of things really can and are very, very important in the fertility process.
Wonderful. No, thank you for the clarification on lifestyle factors. And I'm curious, when we talk to a lot of people that come to us and they're concerned about long-term implications of lifestyle. So can you talk a little bit about how to think about, even the stress of, I wasn't well behaved 10 years ago. How does that might impact my fertility going forward? How should they think about that?
So lifestyle is something I think we all try to strive to improve in all of our own worlds. And, by starting early and thinking about fertility, thinking about lifestyle and how it impacts fertility can actually really help in the long run. So it's not just in the ability to get pregnant, it's the ability to have a healthy pregnancy, and it's the ability to be healthy into parenthood in whatever shape that takes, whether it's through a biological pregnancy or however family building happens. And so lifestyle is important for the long term. As far as previous lifestyle, if people misbehave, so to speak, in college and whatnot, we are pretty adaptable creatures, and there are ways that we can improve these things through, like I said, weight loss, reducing some of those risks, reducing some of the habits that we know can have some bad long-term impacts.
That's great. Thanks for clarifying. Well, we had a couple of questions come through that I was seeing. One of these actually goes back to the prior slide. So either Dr. Stevenson or Dr. Chappell, you can address this. We talked a little bit about female red flags. What are the male red flags that we should be looking for?
So with male flags, sometimes they can be pretty subtle. And sometimes, very often, when there is a male factor diagnosed, we don't often know until there is a problem in family building. Perhaps, through regular intercourse, it's well timed, doesn't seem like there's anything wrong with the female cycles. And sometimes it's at that point that a semen analysis is done, and that's when a problem is detected. There are things that can precede that. So if there is a libido issue and an inability to have intercourse, certainly those things are something that can be brought a little bit earlier in the process. Very often we see those issues at the time of diagnosis.
I would echo what Dr. Stevenson said. Honestly, the two things here are abnormalities in the semen analysis are extremely common, and semen analyses are pretty darn cheap to get. So I am a strong advocate for saying the first step in a fertility workup has nothing to do with the female. It's get the guy to do the semen analysis, because you're going to find a problem almost half the time. And that's usually the first step in recognizing there is a problem. So there are three things that I tend to look for guys to see if there are red flags there. Number one, do they have any medical conditions already? So folks that have diabetes or other inflammatory conditions, or they have a history of trauma or surgery to the pelvis, what's in their medical history there? Those things are the bigs. A history of undescended testicle, most guys don't know that, but they'll say, my mom told me that I needed to have a surgery when I was 2 days old. That's a bit of a red flag too, because that means an undescended testicle, and that can be a problem. So history of surgery, trauma to the pelvis, or medical conditions that they're being treated for, some of those can cause issues with fertility. Number two, testosterone. So that's the other big one, is you say, is your husband on any testosterone or steroids or bodybuilding supplements? Not all bodybuilding supplements like protein powder or creatine or anything like that are necessarily inherently bad, although soy protein can be bad for males, not necessarily females, but that's something maybe Dr. Eskew may want to speak to with her background. But testosterone is a major effective contraception for men, and most of the guys that are on it, and I see a couple a week, have no idea. So prior medical issues or surgery to the pelvis, testosterone, and then the third thing that I say is just get the semen analysis, because the other things that are undiagnosed, we're going to diagnose through the sperm. that is such an important, because guys don't see doctors. I haven't seen a doctor since I was like 12, and I am a doctor. So, guys need to go see a doctor, but they don't know they need to go see a doctor until their wife forces them to have a semen analysis that shows there's a problem.
Those are great points. Start with the male. I love it. I have not heard this yet, so this is great. Well, wonderful. There was one other question that came through. This is around basically, am I good if I'm getting my period? So, I think there could be some misconceptions around, well, I'm getting a regular period, I must be ovulating, right? How should we think about that? Dr. Mbaye, I know you talked a little bit about this, but I'd be curious if anybody else has thoughts here too.
Yeah, I'd say a couple of things. I mean, having a regular cycle, like Dr. Chappell said, is kind of like another vital sign for me, but that's not the only piece, right? A common question that I get is, if I have a regular cycle, does that mean my fallopian tubes are open? And that's where the sperm meets the egg. And that has no indication on whether or not you have open fallopian tubes or not. Are your cycles painful? Are they extra heavy? Kind of characterizing that, because if they're regular, I think that regular can mean a lot of things to different people too. So some people will say, well, I have regular cycles and they're every 19 days. I'm like, okay, but that's too frequent, to Dr. Chappell's point. Or I have regular cycles and they're every 2 months, and that's too far apart. So, regular cycles between every 21 to 35 days is considered, normal. And you can find additional information about that on ACOG's website as well. That was one of the resources Dr. Chappell mentioned. But the vast majority of the time, if you are having regular cycles, then you're ovulating. You can do a simple blood test in the second half of your menstrual cycle to have that confirmed. If you don't want to torture yourself with the ovulation predictor kits and the basal body temperature, which again are just screening, they aren't really confirmatory of ovulation either. But to know, just because you're having regular menstrual cycles doesn't mean there can't be something else going on. And is still, if you kind of hit that time frame, 6 months to a year, going in and getting additional evaluation that's needed.
And just to add to that, you can have regular periods and still have other things going on in terms of painful periods. That could be a sign of endometriosis, adenomyosis. You could have fibroids and not know that. So it's definitely still very important to make sure that things are okay.
Wonderful. Great. Well, if anyone else has any other questions, feel free to submit them. Otherwise, I'm going to pivot to some of the top takeaways. So we've talked a little bit about some of the questions and high level topics, but for the panelists, I would be curious, what would be your 1 to 2 top takeaways for the group today, especially if they're just starting to plan, as a lot of our attendees today are. What are the things that you'd want them to keep in mind as they start down the path? We'll start with Dr. Eskew, and then we'll move from there.
Yeah, so I think one of the most important things is, I think that social media has created a lot of community in a really good way. But again, just kind of being wary of where you're getting your information from, and kind of the comparison trap. I think it's really easy to fall into, well, they did this, so it must work for me, or they said this was the thing that they swore by, so it's going to be the same story for me. And every individual is very unique and different. And there's no one size fits all approach for fertility care for anybody. And I think keeping that in mind and knowing like your journey is your journey and it's unique, and being mindful of that is incredibly important.
That's great. Dr. Stevenson, do you want to go next?
Sure. So for those who do, travel down the journey and do encounter problems and ultimately have to, seek out the care through reproductive endocrinology, I would say, build your social network. Make sure that you, have people that you trust that you can talk to. It's stressful, it's complicated, and having that trustworthy social network will be really, really important. And whether it's a sister, a friend, somebody who you can talk to, but also finding peer support, finding other people who are going through it as well can be extremely helpful and less isolating.
Yeah, I couldn't agree more there. Dr. Chappell.
So I think that for me, what I find myself telling many folks that I just talk to casually, either at dinner or in the hallway or that text me somehow, I just say for the most part, it's starting out kind of and dipping your toe in this journey, or even trying for a few months. Find what works for you and do it as simple as possible, because this is procreation, but we're humans and you're a couple and you're trying to do something pretty important and magical. So it's also somewhat recreation. So don't stress. I have some patients that have 3 different versions of OPKs and they're logging on 2 different apps, and they've got this other progesterone test that they're doing, and they read these 6 books, and that's information overload. You need to have a basic modeling and a basic understanding of your cycle and your health and your basic wants, and then go from there. So I'd say strip it down to something that's manageable for you, that you can actually bite off. Don't get lost in the data. Just take enough there to have an understanding of who you are and what you want. And then the next thing I'll say is be your own advocate, because if you're not getting the answers that you need, then escalate your care and look for someone that can sit down and talk to you at your level. And even if that's like, I talked to this reproductive endocrinologist and I asked them the question, I don't really necessarily jive with those answers. Ask for a second opinion and go talk to someone else, because we all have different personalities. We're all different kind of humans. We want to be able to kind of sit down at your level, meet you where you are, and just help you through your space. Our job is certainly to try and get as many pregnancies as we can, but really our job is just to help folks through their pregnancy journey. So I think that you asking those questions, asking, and to Dr. Eskew's point, who am I talking to? What, you're a doctor. What are you a doctor of? What's your credentials? Where is this information coming from? And what I tell patients is, if I tell you anything, if I give you any statistic, you ask me where I got that from, I will show you the study. You don't want just someone to say, oh, I had a patient like you that did that once. You want people, there's a reason we do all this training. We know what the thousands of women that came before you that have your story did. Here's the research behind it. Here's why our recommendations, we think they work based on this research. So you step up to the plate and say, this is what I want. This is why I want it. How do I get here? And let us, kind of guide you through that. And then all the while trying not to stress too much with just data overload.
That's great points. And you mentioned this term before. So can you define OPKs?
Sorry, ovulation predictor kits. So we're talking about, regular ovulation or not regular ovulation. Even in someone that's having regular menses, they're only ovulating 93% of the time. So it'll drive you nuts. But OPKs are the where you pee on the stick to see if you're ovulating. Sorry.
No, I just wanted to clarify. That's what I thought too, but I wanted to make sure.
Yeah.
All right, Dr. Mbaye.
Yeah, so I think my biggest thing is kind of a 2-part thing, but first, just to always remember that while that first pregnancy is obviously important, so is that second, third, fourth pregnancy, depending on what your overall family building goals are. Just always keep that in mind, especially if we know that as we age, success rates kind of go down a little bit. And in thinking about that, just always be proactive in getting care as early as you can once you see that something is not right. So I forgot who had mentioned it before. If you notice that your periods are getting shorter or they're getting heavier or lighter or something is changing and you're not sure what's causing that, that's a good reason to be seen by your OBGYN, by your primary care, to at least make sure that there's not some underlying issue going on that you would have done better knowing about now rather than a year or 2 years down the road.